Can you guys see that?
Yep.
Yes, no? Cool. Yeah, so my name's Ethan. I worked with Kayla, Jana, and Lexi and Nicole. So yeah, we looked at the lack of access to sexual healthcare and how it influences young adult females. So the access to reproductive healthcare for young women in the United States has been an extremely important topic in the midst of the controversial evolution of reproductive healthcare accessibility. So we aim to look at how the lack of access to sexual healthcare influences young girls. So a large portion of sexually active young women in the United States report using some form of contraception. So this is an important factor in reducing unplanned pregnancies. A barrier to contraception use is a huge lack of knowledge. So education, which as you would expect, affects the use. In fact, a majority of education revolves around abstinence-only sex ed, and this affects young women who do decide to be sexually active. This makes up a large portion of the United States. Planned Parenthood, as we all know, provides affordable access to reproductive health care. A study done, so this was you guys look at the design and implementation section, that first bolded part there. It was a study done in Texas that explored different implementations that reduce Planned Parenthood. And this showed to have drastic effects. So of those effects, we saw a decrease in contraceptive use, a decrease in appointments, and yes, a 27% increase in childbirth during that period of time. So what do we do about the push to restrict these different services? Well, we need to implement interventions that include education and increase the access. So specifically for young girls. So and young girls actually happen to have the worst sexual and reproductive healthcare outcomes than any other age group. So if you look at the outcomes section there, or organizations like the ACOG, the Power to Decide, and the Office of Women's Health all provide women with education and low-cost reproductive health care. And these are resources that need to be talked about more. Take-home message for our poster would be that there are consequences for restricting the education and access regarding different sexual health care for young women. So in essence, that's kind of what we studied here. I hope you all enjoyed that, and I guess the floor is open for any questions if you guys have any.
Yeah, Ethan. Yeah. Any questions for Ethan's group?
Do my best here. And if not, that's also fine. But yeah.
What would you say was the most interesting thing you learned as you kind of looked into the research related to this topic?
Yeah, I mean, I think the most important thing here was that study done. You saw huge decreases in the use of different contraceptives and a 27% increase in unplanned pregnancies, which I think is big. And I think we can learn from that as well. So, yeah.
Absolutely. It's certainly a very timely topic and very interesting. So I'm glad that you were able to take a look at that, and I think very beneficial for many of you going into future healthcare careers, just to kind of know what the landscape looks like related to this. So
yeah.
Any other questions for Ethan's group at all? Very interesting topic. You guys did a great job on this.
Thanks so much.
I had a quick question.
Sure.
Would you say within your guys' research that funded birth control has gotten better over time, or is it more of on a decline and something that needs to be reevaluated?
Yeah, I think it's something that has to be re-evaluated. It definitely goes up and down as far as how much access is available. We kind of looked at like how the lack of it affects young girls, but I'd say we're on a better track now without getting too political.
Thank you.
Yeah.
Great. Well, looks like that was all the questions for your group. Very, very interesting, and appreciate you kicking it off. You did a great job with your first one and had a nice kind of well-packaged presentation. So great job, Ethan.
Thanks so much, man.
Let's and I should mention too, we would really appreciate, even if you're kind of one of the earlier groups, to go to be able to stick on the call, similar to like if you were to attend a conference and kind of mingle with the groups. I think it's just nice to have, as the groups go on to the end, to still have an audience. And the nice thing about going tonight, I don't know if you got this schedule for tomorrow night, but tonight's about half the amount of time as tomorrow night's group. So you guys kind of lucked out in that respect, that will be done in a little bit shorter amount of time. Why don't we shift to our next group, which is Team 4, which is Sydney, Amelia, Linda, Caitlin, and Caleb. And again, if any of you want to take a look on the website, the poster is titled Impact of Access to Cancer Prevention Information and Annual Cancer Screenings. So I will turn it over to your group.
Yes, I will be presenting. Let me turn my screen on here. So I still need to get everything figured out sharing wise. Sorry about that.
No problem. No problem. Yep, that green screen share button should allow you to bring the whatever screen you're using up. And if you don't see that screen, I can try making you a co-host, and that might help.
I think it has something to do with my system settings. Just trying to ask one of my group members to help me out. But
if any of Caleb's group members are able to screen share, feel free. Or Caleb, another thing I can do here is I think I could screen share for you.
okay.
And let me just find the right screen.
Thank you very much.
Yep. Let me just, this is the correct poster, correct?
Correct.
Let me just zoom in a little bit here. Is that better?
Yes.
Okay.
Amazing. Awesome. Yes. I'll introduce myself. I am Caleb Story, and I'm presenting on behalf of Caitlin, Sydney, Amalia, and Linda. We made this poster, and it's about the access to cancer prevention information and annual cancer screening. More specifically, the aim was to answer the question of how access to cancer prevention information and annual cancer screenings in adults aged 40 and older impact cancer diagnosis outcomes. So to be upfront, the answer to this question is that access to cancer prevention information and screenings does improve outcomes. Cancers will be detected earlier and thus be addressed and treated earlier, improving mortality rates. In regard to interprofessional collaboration, patient outcomes also improve. The interprofessional team can work together to educate the patients on cancer prevention and importance of cancer screenings. A personal story of mine also shows the importance of the interprofessional team in regards to the education of cancer prevention and cancer screenings. My grandmother has breast cancer, and around 15 years ago, she was going to all the doctors thinking that she had breast cancer, but nobody would confirm it. They kept saying, turning her away. She was going to a physical therapist at the time as well, and she was working in the underarm region and poked in one area, and she experienced like major pain. And because of his diverse knowledge, he knew that she had breast cancer, referred her to a doctor, got another mammogram, and sure enough, she did have stage 4 breast cancer. She's still fighting, 15 years later, but just a great example of how the interprofessional team can work together to improve patient outcomes and improve the mortality rates of a specific type of cancer. One statistic that we found was very interesting was if you look in the outcomes of cancer screenings portion of the poster, it says that a study found that breast cancer mortality reduction of 70% in screened women compared to unscreened women. And then finally, I'll direct your attention to figure 1, which is that diagram in the middle bottom portion of the poster. We thought this was very interesting as it shows the percentage of women that have reported getting a mammogram and if they had insurance and the type of insurance. So on the right portion of that diagram, it showed that 72% of insured women had a mammogram within the past 2 years. And then it kind of trickles down as it moves into the uninsured or the lesser types of insurance. And so we also, for the background information, we saw that everybody does have access to cancer screenings. When it comes to people who are uninsured, the Affordable Care Act through Obama gave everybody an opportunity to get screenings. And so it doesn't necessarily matter if you have insurance or not. Everybody has access to free screenings for cancer. And if anybody has any questions, they are welcome.
Really interesting. And, I think the field of cancer and oncology is a huge one for interprofessionalism and collaboration, professional collaboration, because oftentimes there's many, and you might have seen this with your grandma or other folks on the call may have seen this with their own care or other family members. There's often, and I think your box down there kind of highlights this, that there's many people involved in kind of the early stage diagnosis, a lot of people involved in helping someone properly care, from dietetics, and sometimes it is, post-surgery, OT, PT, certainly nursing, physicians, PA. And so this is a field that's really ripe for collaborative care and having really positive outcomes. So yeah, very, very good presentation. Any questions for Caleb or Caleb's group on this topic? It's a really interesting topic. Well, thank you. Yeah, this was.
I'll just make a comment, Brian, that a lot of news in relationship to mammography and COVID in terms of the screening reductions that have gone on. So we're going to see the repercussions of that now. Probably coming up fairly soon because people miss their screening appointments. So
Yeah.
Sure.
Yeah, it's a great point, and I think across the board, I think there's I think ongoing research into the fact that there were kind of an increase in deaths across the board in 2020, and some, especially in the early months of March and April, when it looked like people were not going to the hospital for, you know, all types of things that maybe could be life-saving or preventative, like stroke or heart attack, and certainly early detection of cancer, I think, would be another one. So it's going to be interesting to see how this continues to play out. But yeah, that's a great point. Well, thank you. I will do a stop screen share here, and we'll invite our next group, which is team 5, composed of Brianne, Laura, Alexis, Rebecca, and Gabriel. And it looks like I like to do a little topic here.
Hi, I'm Brianne. I'm the one that's going to be presenting, but I'll have Laura, another member of my group, share the screen if that's okay. Perfect.
And if you have any trouble go ahead. Looks like you're all set.
Yeah, I think we got it. Thank you though. So my name is Brianne Nichol. I am on a group with
headphones. You don't have to listen to it.
I'm in a group with Laura, Alexis, Rebecca, and Gabriel. And what we looked at was Hispanic immigrants in the U.S. and how they're suffering from disproportionate access to quality healthcare compared to non-Hispanic white citizens in the U.S. So first, I'll give a little bit of background about social determinants of health and kind of how that plays into our project. So these factors are independent factors within a person's life that determines their access to quality care. These can be socioeconomic status, immigration status, race, ethnicity, and education regarding health in general and health habits. Within the legal as well as unauthorized Hispanic immigrant populations, poverty was really prevalent, and it played a significant factor as a social determinant of health. Especially disproportionately affecting the rates of uninsured populations. It's vital that society and healthcare providers alike rectify these disparities, in healthcare, because the diversity in the United States is increasing, therefore calling for a significant change in the way that healthcare operates specifically for this population. Moving on to the significant section, members of interprofessional teams in healthcare must be really competent in order to deliver proper care. This requires the use of skills such as communication, knowledge, clinical reasoning, and values for the benefit of the community that they're serving. Each professional is responsible for their own competencies so that they can make sure that they're not neglecting any areas of care. Specifically with the Hispanic immigrant communities, they face a variety of barriers that are not seen by a lot of other communities or a lot of other populations when accessing healthcare. And if a provider or a healthcare service is unaware of these, it can be really detrimental to the community's health and result in a lesser level of care. So healthcare providers on interprofessional teams are responsible for remaining culturally competent and aware of the needs and challenges that the community faces so they can deliver effective care. This can be accomplished through healthcare systems implementing educational training programs for their employees so they can be aware of diverse populations, and when they encounter and recognize challenges seen by specific populations such as Hispanic immigrants, they can make sure that the provision of care is improved. Moving to the findings section of our project, while assessing and researching this topic, the social determinants of health, basically that Hispanic immigrants may face in America, we found a lot of factors that suggest these immigrants in this population experience healthcare access disproportionately compared to the rest of the population. Low English proficiency was one of the factors that we observed that definitely created a barrier, a language barrier between patients and physicians. And this specific aspect puts this population at a higher risk of adverse outcomes such as drug complications and decreased patient satisfaction, as well as health dangers of miscommunication of treatment plans between patient and physician. Additionally, we found that there was a high rate of uninsured US Hispanics compared to non-Hispanic whites. And this non-citizenship status may contribute to this, which And the reason for that is because it inhibits program eligibility and comes with stigma and fear of deportation. Some of the reasons we observed that Hispanic immigrants, especially immigrant women, felt that they faced a barrier to access to healthcare in the United States included the high perceived cost of medication and services, which puts a burden on lower income families, inflexible work schedules, and having only one parent available to, say, like take care of their children, lack of interpreters in a wide variety of healthcare settings and facilities, and as well as difficulties in finding modes of transportation to appointments, or lack of general education on how to create and organize a proper healthcare schedule. So some solutions, moving on to that portion of our project, looking at our findings and incorporating that with the significance of this topic, some things that we really valued and said that our solutions need to incorporate is to overcome the language barriers that are present with this population, as well as to expand on cultural competency in healthcare providers and employees in healthcare, as well as the use of promotoras, which are outreach programs that have shown to improve healthcare access and quality based on the research that we've seen. And to give a little background about promotoras is they reach out to those within Hispanic communities that need healthcare and provide them with the help and resources that they need. Focusing on cultural competency, educating employees is the best solution we found to improve this. It would largely include a focus on interprofessional education and interprofessional teams, focusing on the cultural competency aspect. We also wanted to address with our project the need to increase education on free clinics and health screenings for uninsured Hispanic immigrants, because we found that a lot of them, that is really a big inhibitor to access to care. As well as increasing health departments' expenditure to underserved communities, which would specifically pertain to this population. And increasing federal funding to these locations definitely would contribute to a solution. So overall, solution to providing proper medical care for this specific population is to reach out, have information readily available, as well as making it accessible and feasible to anyone, even if people from this population don't have insurance, because that, again, was a big factor. So that's all. Let me know if you guys have any questions. My group members can help answer as well if they want.
Great job, Brianne. That was an excellent overview. Any questions for their group? This, with professional education research, this is a pretty timely topic too, as are many of these. And I wanted to just kind of call attention to the fact that in the fall, our MyPERT conference, which is kind of our annual interprofessional regional conference, is going to be relating to this topic directly. And I did that intentionally, had this program kind of fit well with that. So many of you, the topic is actually called Expanding Our Reach, Responding to the Needs of Diverse Patient Populations Through Interprofessional Advocacy, Education, and Research. And so if any of you are interested in possibly presenting your posters at the MyPERT conference, that might be a great opportunity for some of you to get increased exposure for your group and some of the research that you're doing, because these are all topics that relate very well and are very timely. But yeah, thank you, Brianne. That was really well done. Any other questions for their group? Well, thank you again. You guys did a really excellent job, as have the other groups on this, and that was a very informative presentation. So thank you to you and your teammates for that great work. Let's shift next to team number 6, which would be Christopher, Kaylin, Olivia. And again, if you have any trouble screen sharing, let me know. It looks like that yours was related to healthcare access. Looks like accessing healthcare regarding differences in Michigan County's income. So with that, we will turn it over to you. And Chris, if you start, I look like it.
You see my screen now?
Yep, yep.
Okay. I was having some issues unmuting it. Okay. Hello, I'm Christopher Allen. My group members are Kaylin Quinn and Olivia Sunday. The title of our presentation is Accessing Healthcare Regarding Differences in Michigan County's Income. The purpose of this poster is to see if there's a correlation between wealth and access to healthcare. Access to healthcare is critical for a healthy population. According to Lazar and Davenport 2018, access to care is not only the ability to reach care, but the care provider must also accept the individual's insurance along with providing culturally competent care. If I could have everyone move their attention to figure 1, it's at the bottom. The 2 maps of Michigan. The map on the left in green ranks how healthy people are in each county throughout Michigan, and the map in the middle, that's blue, ranks the quality of the health programs within each county. The lighter the color of each represents a more positive ranking. A correlation can be seen between how healthy people are versus the quality of health programs located within their county. On the far right picture of figure 1, West Michigan counties are included. West Michigan counties can be viewed on how they rank in each category. Ottawa County tends to lead the ranks. As they do in this one, they were listed in first place for how healthy people are in that county. The 3 most impoverished counties in Michigan include Lake County, Osceola County, and Arenic County. They were all ranked low or were in the dark green on the map. These same counties ranked low on the how healthy the people are, which can be seen by how dark blue on the map. Conversely, the 3 wealthiest Michigan counties, Washington County, Oakland County, and Leland County, ranked high on both the averages of how healthy their citizens were and the quality of their health programs. Our research has shown us that increased access to health care generates fewer disparities. Some barriers we found that may impact access to health care include lack of insurance. In Michigan, 7% of children and 11% of adults are uninsured. Secondly, 38% of whites, 55% of African Americans, and 60% of Hispanics identified poor access to vehicles as a barrier that may result in missing health treatments and having lower overall access to healthcare. We felt like that was with Uber, Lyft, and all the other services that are available, that would, in most locations, be something that could easily be ameliorated. Lastly, education. In Michigan, the healthiest counties tend to have the highest level of education. And a few sustainable solutions to improve access to health we came up with included, firstly, improving or increasing locations of healthcare facilities within those particularly lower ranked areas. The hope is a closer location for everyone in those lower ranking areas, which would provide adequate healthcare and would also help if they are in that high percent people who do not have transportation. Secondly, a government or insurance fund for the transportation itself to and from the provider. This would provide a travel option for single parents who may not feel they can use the bus system in the area if they have one. And lastly, promoting the achievements and benefits of education throughout a community outreach program. This may show options to people that are in the area while also reversing negative stereotypes that may be associated with continued education in their area. That's all we have. Thank you. does anyone have any questions?
Great job, Christopher. Looks like there's one in the chat. I'll read to you. Do you know what determined the quality of the healthcare programs? Was it maybe like better health outcomes possibly, or something along the lines of more coverage for everyone?
Hold up. Was that for the quality or the? Was that for the quality side or the healthy side? They didn't give direct answers though for either, so they didn't give specifics how it's. They rank it once a year, but they didn't actually go into how specifically they chose that.
Sure. This is a very good topic, and you know, rural communities are actually one of the more disadvantaged communities related to healthcare across the country. And you know, part of that I think you brought up is both lack of access, but then sometimes transportation.
Yeah, because the amount of people, the percent that were insured was for Michigan is quite high, but the transportation was, we were quite surprised by that actually.
Yeah. And if any of you have visited the UP, I mean, you see a number of those in kind of northern, even the lower peninsula, and also certainly the upper peninsula. Sometimes it's difficult, you know. I mean, I think in a little bit more urban, suburban communities, it's easier to, like you said, maybe use ride-sharing services or public transportation. But in some communities, it can be quite a haul to get to where you might find, you know, especially if you need more advanced care beyond just something like, you know, general checkups or wound care. Some of that can be a little bit of a haul. So I think it's certainly something that can be addressed, especially with those of you that are kind of looking at a more public health angle to your healthcare work in the future. This is certainly one to keep in mind.
Absolutely, thank you.
Yeah, thanks, Christopher. Great job. So our next group on the docket is actually going to be going tomorrow. That's the Grace, Keely, Madison, Abigail group. So we're actually going to jump to Kayla, Brooke, Isaac, Logan, Megan, team number 8. And if you're all set, we can turn it over to you. It looks like the topic relates to the relationship between head protective gear and motorcycle safety.
Yes. So should I just share my screen? Oh.
And Chris, you might have to do a stop screen share so that, there you go, perfect.
Okay. Can you guys see it?
Yep.
Okay, perfect. Hi everyone, my name is Brooke Belanda, and myself along with my group members, Logan, Megan, Kayla, and Isaac did our research and presentation on the importance of head protective gear use during motorcycle operation. So to start, neighborhoods and the built environments that people inhabit majorly impact their health and safety, and our group focused on researching injury prevention in motor vehicle crashes. Some background: in 1967, the United States enacted a universal helmet safety law requiring that all motorcycle owners wear a helmet while riding. And within the last 20 years, there has been a major push to remove this law. Opponents believe it is a personal choice to wear a helmet or not. And since this movement, there have been many studies to show the increase of risk in mortality and head injuries while riding motorcycle. We sought to explore the relationship between motorcycle helmet use and head injuries. The population we focused on were adults who ride motorcycles. The intervention were head protective gear. We compared those who do and do not wear head protective gear, and our outcome was to lead to decrease in motorcycle head related injuries. Some significant statistics that we found were the fatality rate significantly increases in motorcycle crashes where the rider was not wearing a helmet. The repeal of Michigan's helmet law resulted in a 3% decrease in helmet use. And when given the option to wear a helmet, only 46% of riders wore one in a study that was recently done in California. And after a law was passed requiring helmet use, 99% of riders reported that they were wearing a helmet. And more than 100,000 citizens have died in a motorcycle crash, and this was done in a study in 2007. So almost 14 years later, there is most likely a significant increase in that number. And in fact, only a couple weeks ago, I was driving down 196 in Grand Rapids and saw a gut-wrenching motorcycle crash. And I just hope that the rider is okay and was wearing a helmet. And this just shows that crashes still happen no matter how alert drivers and motorcycle riders are. And it just stresses the importance of wearing a helmet. Onto our design and implementation. There are two types of helmet laws: a full helmet law, which is associated with a decreased mortality rate, and a partial helmet law, which was found to be associated with an increase in mortality rate. So using full helmet laws will decrease the mortality rate amongst riders. And using a Department of Transportation approved helmet will drastically increase survival rate for those involved in a crash. And this is because the Department of Transportation demands a certain level of safety from helmet manufacturers. In our community, awareness should be spread of the risk of not wearing a helmet, and these risks include head injuries, spinal cord injuries, other body injuries, and fatalities. And risks can be limited by using proper headgear and instilling full helmet laws. Some outcomes that we found was the repeal of helmet laws have significantly increased the incidence of head injury and death. It resulted in a 24% to 27% helmet use decline among riders in crashes and a 14% increase in head injuries. Universal helmet laws are associated with a 36% to 45% decline in motorcycle crash mortality, and only 0.5% of motorcycle crashes with head protective gear receive severe head trauma, which is a significantly low amount of people who, when they are wearing their head protective gear, will result in a head trauma. So this shows that not using head protective gear is directly related to an increased risk of injury and or death. In conclusion, roadway safety is a critical aspect of creating healthy built environments, and the use of helmets when riding a motorcycle helps to maintain these safe environments. Helmet use among motorcyclists caused a 36 to 45% decrease in motorcycle crash fatalities, and the research showed that the absence of head protection leads to an increased risk of death and injury. So there is a significant relationship between the use of motorcycle helmets and safe roads. And below is the references we use to gather our information, and thank you for listening.
Great job, Brooke. And one thing that stood out to me was under your significance of box, it said that when they repealed Michigan's helmet law, there was only 3% decrease in helmet use, which is interesting. I would have thought it would have been higher than that. I mean, it seems like in the summer, at least, it seems like more than 3% of motorcyclists that aren't wearing helmets. So I found that number to be interesting.
Yes, and that was in a study that was done in 2017. And hopefully people are still wearing their helmets, and that study was done in like a large group. But yes, it was very interesting to see that there were people that were opposing a law that was really just trying to keep them safe in the end.
Right. Yeah, and that other bullet point that stood out was under outcomes that only 0.5% of crashes with people that were wearing head protective gear had severe head trauma. I mean, that seems like a huge selling point for the importance of not only wearing helmets, but I guess to your point, implementing, what the amount of lives that implementing a helmet law can save.
Mm-hmm.
So yeah, really interesting. And again, many of you, whatever field you're going into that might be healthcare related, I think some of these statistics are really good to know because, this is kind of everyday kind of stuff that you might be seeing in terms of people asking you questions about this or outcomes that you might be seeing based on people's choices. So yeah, very, very interesting topic. Great job. Thank you, Brooke.
Thank you.
And thank you to the rest of your team as well. Great job.
Thank you.
Any other questions for Brooke, I guess, or their team before we shift to the next group?
I just had a quick one, if I could. I was just curious about like what drew you guys to this topic, like what made you guys want to choose this? Because it's super interesting and I would never have thought to look into it, but it's interesting.
Yeah, I know my other group members are on, so if any of them want to jump in on their opinion as well.
It's a great question. Go ahead.
Yeah, I can add to that. Just for me personally, the area that I'm from, it seemed that like nobody wore helmets, and I've known quite a few people, mostly like my parents' age, that got into accidents. So it's kind of just an interesting topic to me personally. Everybody else has different motivations, obviously, but that's just my input.
You know, and one thing to Brooke's point too, that you were saying that these can happen at all times of the day. And, you know, you see the campaigns, especially this time of year, to like look twice for motorcycles and stuff. With the increase in advent of like people wearing, you know, GoPros in all kinds of capacities, whether that's skydiving, surfing, especially on motorcycles, you see sometimes online. And Logan, you probably have seen this if you're kind of into motorcycles and stuff, how quickly sometimes these accidents can happen. And this is true for cars as well. But in motorcycles, you're just, of course, at such an increased risk for more severe outcomes. And these things that are at all times of the day. And probably, you know, it'd be interesting to see if more motorcycle accidents happen during the day versus at night. Not sure if you guys saw that at all, but.
Quick question.
Sure, go ahead.
I don't know if you guys found this all in your research at all. I just thought it was interesting. Did you guys, within your research, ever notice a decline in organ donations? Because I know a lot of times from motorcycle accidents, a lot of people have traumatic brain injuries, and that's a very high, that's almost wrong to say selling point of kidney donations and stuff like that. So do you guys ever see like a decline after the enactment of this law?
I haven't, but that's a really good point.
Actually, it might be an increase because of brain injury. There might be more organs up for transplant eligibility. So it might be the opposite in a way. Sorry, Logan, I didn't mean to interrupt.
Great questions as well. So in the interest of time, let's go ahead and we'll jump to team. Just want to make sure I've got the number right, 9, which is Hannah, Valerie, Hunter, and Riley. And their group had we looked at the effects of early literacy on health outcomes for children. So another very interesting topic. So excited to see what you guys found. So we'll turn it over to you.
All right, sorry, I'm trying to share real quick. Can you guys see my screen all right here?
Yep.
All right, so hi, my name's Hunter.
I'm Hannah, and we're focusing on the effects of early literacy on health outcomes, and the social determinant we're focusing on as well as social and community context. For some background, in today's society, parents and families live a fast-paced life and are consumed by daily tasks and responsibilities. Over the years, parents have moved away from normal activities such as reading to their children at night. This act of reading to their children has great effects on the child's health outcomes. Reading is really important, especially in the first 5 years of the child's life, just because the child's brain is so malleable and really expressive as well. Early childhood literacy can be influenced by various factors, such as socioeconomic status, parental income, and home environments. But intervention programs and resources can be provided to parents to help with child literacy. This topic was originally brought to our attention by a study that was conducted by the National Survey of Child Health, and they collected data from children aged 5 and under and the frequency of them being read to by their parents. From the findings, it was concluded that the proportion of children aged 5 and under who were read to at least 4 days a week was 58.3%, and currently the targeted percentage is 63.2%. In order to increase this percentage, the frequency and occurrence of parents reading to their children will have to increase and will bring upon better long-term health outcomes and literacy for children.
So for the PICO question in our study, we designated our population of interest to be children 5 years of age or younger. Then for our interventions, we researched kids who were read to 4 to 7 times per week by a parent or guardian, in contrast to those who were only receiving 3 or less days of literature exposure for our comparison. Our outcome for this was to hopefully determine that kids who are read to for at least 4 days a week in early childhood would have better academic, social, and cognitive performance later in life, in turn leading them to live healthier and happier lives. So what's the significance of doing this research? We found that children raised in lower socioeconomic status groups will usually have less exposure to books at a young age, whether it is a lack of time for parental involvement or a lack of resources from no public libraries nearby. Also, the availability of education and what kind of school is nearby has an impact. Some schools may push for kids to take books home and have their parents read to them, while others may not. Then finally, the obvious reason that was stated in the PICO question is that kids who have the privilege of parental involvement with books have a head start in development and learning skills, and this will give them a head start in life, making it much harder for kids lacking those experiences. This is yet another example of why we are trying to investigate more socioeconomic factors in healthcare as a society.
For the design section, we use a few different graphs from our research to show the effects that reading has on children and their health outcomes. The first figure at the top shows improved cognition skills, which includes things like literacy, language, numeracy, and cognition in children who are read to at ages 4 to 5. These skills were tested again at ages 8 to 9 to reevaluate the effects of reading and how the child's literacy and other factors improve. The next figure shows children who are read to more frequently have a higher score on other numeracy tests and reading tests, which correlates with increased level of reading achievement in the future years. And the final figure shows that children who are read to more frequently have higher reading skills as measured by parents and teachers at ages 4 to 5.
So our group was able to draw multiple positive outcomes associated with reading to your child. First of all, there was a significant increase in the child's reading and language skills. Second, we could see improved socio-emotional outcomes for those who had more reading experience from a parent. Along with this, they were able to improve their relationship with their child as well. The final benefit we found was higher frequency of positive attitudes toward reading. These all make sense, since a deficiency will not only put them behind academically, but also in a social aspect with those around them. And a difference at a young age could impact them throughout their entire academic career and maybe even longer. But also, these benefits clearly show how important of a difference such a simple task can make. So we created a few different ideas for intervention to help kids in the disadvantaged have equal opportunity.
The first idea for an intervention program would be some kind of program that parents and their children can use to promote scheduled out reading times at night in order to give that time to actually provide that literacy. Another idea for intervention is an educational program that provides resources such as books to help parents enhance their children's literacy and reading skills. The overall goal of this research is to promote healthy habits, as if the act of parents reading to their children, in order to ensure better health outcomes for children later on in life.
I know our references section didn't show up there. We had it on there. I don't know what happened to it here. Yeah, see, it's on right there.
Sure.
Sorry about that.
No, it's a great topic, and this is one that I have seen a concerted public health effort towards this. We have little kids, and at the library, there's these charts where if you hit a certain benchmark, you can add their name to the wall. And through the school, there seems to be increased attention and focus on this one. So it seems like this word, as it pertains to this one, word is getting out. Certainly more work to be done, but definitely I think one that seems to be a concerted effort being put towards. Any questions?
And I do have their poster with the references, just so everybody knows.
Yeah.
For some reason, that box is just not showing up, but I've got it here on my end. So.
Yep. Looks like it's on the one on the website too. So good.
Yeah.
Yeah, great job. Very interesting topic. Very interesting topic.
Thank you.
And again, I think many of you are going into helping professions broadly, and if it's healthcare, I think a lot of these are ones to just really think about and refer back to or file away in terms of conversations that you might have with folks at different life stages, in terms of things that can really, there seems to be some real direct correlations here between our early childhood literacy and success later in life. So, yeah, great job.
Thank you.
If no other questions, then let's jump to our next group, which is team group 10, Vanessa, Sienna, Lexi, Jing, and Marissa. And it looks like your topic was about pediatric food deserts. So I'm excited to hear what you found and what you wanted to share with us.
Hi, is my screen showing up okay for everybody?
Yep.
Okay.
Thanks, Lexi.
Awesome. 1 second, I just want to there we go. Okay, hi, my name is Lexi, and I'm presenting on behalf of our group. We decided to research pediatric diabetes and the relationship to food deserts. So just for a little background, food deserts can be defined as an area with limited access to affordable and nutritious food, and it is a form of a food insecurity. So I just want to highlight that I know it's food desert, but it doesn't necessarily mean that there's just a complete lack of food. It could mean that there's a lot of food options, but they're all just of poor quality. So the food deserts can be linked back to kind of what area it is, but also we found a correlation with socioeconomic status in that area. And on the flip side of that, in regards to pediatric diabetes, there has been a dramatic rise in children with type 2 diabetes, which is a preventable form of diabetes, for those of you who don't know. So looking at both the rise in food deserts and in type 2 diabetes, we decided to research the relationship between the two of them. So our PICO question was, what is the effect of food deserts on the development of diabetes among the pediatric population? So we did find a relationship between food deserts and pediatric diabetes within the population of people who would live in what would be considered the food desert. But in addition to that, we also found that children in food deserts were vulnerable to other conditions such as malnutrition, obesity, hypertension, and even decreased cognitive abilities. And in addition to that, we also found that so we know that it's not maybe different in rural and urban populations based on what the food desert is. We found that the rural was more the places that did have the lack of food, and the urban was more the places that had the food, but it necessarily wasn't the best quality. But we did find that the combination of low income and rural families were struggling the most with living in food deserts. We found that the childhood obesity rates were also pronounced in the youth of the people living in the rural areas. We overall found, for where this affects people later in life, that these people living in food deserts, and specifically the pediatric population, were taking these food habits that they were developing and the food insecurities that they experienced when they were children, and they were taking that into their adult life and keeping those bad habits, and ultimately they still had the effects of their diabetes because they developed it when they were children. So some things that we looked at for solutions included kind of addressing the aspect of the community-based, so the rural versus urban, and also the socioeconomic status part of it. And we found that there could be programs implemented that kind of combat the issues with not having great food. We also thought of ideas such as implementing point-based reward systems for families that are low income, and kind of creating like a reward system for participating in and choosing healthier options for food. And to address the issue of the community-based problems, we looked at implementing like food pantries and food banks, and kind of developing healthier options through those ways. So to summarize, we found that food deserts which are areas of limited access to affordable and nutritious food, have had a negative impact on the health of the pediatric population. This includes not only the development of pediatric diabetes, but also other health issues such as obesity and hypertension. So we thought of some good solutions by looking at the socioeconomic status and the community-based origins of food deserts, and decided and researched some solutions there. So yeah, so thanks for listening.
That was good. I like the kind of the chart that you've got in the middle too, that just kind of showing how interrelated some of these issues are.
Yeah, it's kind of they all kind of intertwine in a very interesting way, where like the food deserts affect, you know, the pediatric populations, but the socioeconomic status affects the food desert. So yeah.
Many of you are probably familiar with Kids Food Basket in Grand Rapids, and they have just grown immensely, and I think won a lot of community-based awards for their work in the West Michigan community. And I think really trying to target some of these issues that you brought up, and providing, initially started as lunches, but has now shifted to, I think, and if some of you, I think breakfast, lunch, and dinner for many families, at least lunch and dinner, I know that they're trying to provide. I know COVID probably impacted that a little bit in terms of what types of food they were able to provide, but that's another, I mean, it kind of goes in that first bullet point when you talked about a fresh fruit and vegetable program. It kind of reminded me of the work that they're doing. Any other questions for this group? Yeah, really excellent topic. And again, I think one that touches on many different aspects of healthcare providers and helping professions. You know, it's one that I think is not only across the country, but even worldwide. I think some of these issues are important. So I'm very glad that you presented on this, because I think this is a real interesting topic.
Well, thank you.
Any other questions for their group? All right, let's jump to team 11, May, Michael, Jared, Brendan, and Matt. And it looks like their topic related to impact of increased accessibility to chronic illness education on rates of type 2 diabetes in adults. So a nice kind of piggyback off the presentation related to type 2 diabetes in children. So we will turn it over to you.
All right, I can share my screen real quick. Showing up nicely.
It is, yep.
All right, so Michael, if you want to start with the background, then I can go off of that.
Yeah, I'll go ahead and start. So my name is Michael. This is our group project about diabetes type 2 rates in adults and the impact that can have on accessibility to chronic illness education. We also had Maya, Jared, Brendan, and Matthew were also in this group. And just some background information. We decided we wanted to look at something that was diagnosed and could also be prevented. And in the United States, more than 35 million Americans suffer from diabetes, and it's estimated between 90 and 95% of those cases are type 2. And quick background, type 2 diabetes is caused by insulin resistance or relative insulin deficiency. And so I guess if we just want to do the significance of now.
Yeah, so the significance of this is that of the 35 million people that suffer from diabetes, 1.5 million Americans are diagnosed with this every single year. And of those people diagnosed with diabetes, 210,000 are children and adolescents younger than 20 years old. So it plays a really important role in trying to roll out the increased accessibility for our chronic illness education. And I mean, diabetes is a major component of the chronic metabolic disease. Not only does this disease lower the quality of life, but greatly increases medical expenses linked to the disease and related deaths. And on our significance portion in the lower part, we have a little graph, and it shows the estimated age adjusted prevalence of diagnosed diabetes by race and ethnicity and sex among adults younger than 18 years old. So this is a little bit before adulthood. And when we go to our literature review, we're looking at a couple different cases that we saw. For Article 1, increased self-care activities and glycemic control rate in relation to health education. This article describes randomized clinical trial to further prove that education could increase the basic health care skills and glycemic control rate in patients with type 2 diabetes. And results found that patients participating in these classes in conjunction with conventional diabetes treatment can improve glycemic control and self-care skills. So it really goes to show that education really does improve the quality of life with dealing with type 2 diabetes. And so, Michael, you want to do the fun facts?
Yeah, so just some of the fun facts we kind of wanted to touch on was in the age of COVID that we're in right now, people that have diabetes have been kind of put up on that list of vaccine on the vaccine registry. So they've been able to get it a little bit earlier than some other people. And healthcare education has also been shown to increase a lot of stuff, not just chronic symptoms, but also just mental health, physical health. And it's also just, it helps to prevent drug and alcohol abuse as well if you're educating people on the effects of that. And the third thing we found out was just looking at kind of when health education really skyrocketed in the United States was right around the 50s to the 70s, which also kind of coincided with the presidential appointment for physical fitness, which was a big program, I think in the 50s, 56, I believe, where the president tasked an entire group of people with increasing the physical fitness and health of the youth in America.
Yeah, and some of the outcomes related to our literature review showed that that there's a significant increase of self-efficacy score when given the proper education. And for Article 2, something a little bit more technical, that the glycated hemoglobin levels decreased from 1.07% versus the control group. So showing that those that did have the education were able to better control their hemoglobin levels than those that didn't have the education. And that reduction in the negative mental health symptoms associated with the chronic illness was also a qualitative outcome that we saw. And a lot of health wellness programs are a cost-effective way to help those in all socioeconomic levels when tailored to a cultural aspects or specifically the individual. And the US diabetes cases projects that diabetes will increase 165% by like 2050. So making sure that there's enough outreach programs, especially for the underserved communities where healthcare is limited due to resources or insurance or low income areas, is critical to help curb the projected numbers of type 2 diabetes cases. So kind of in summary, patient access to quality health care education shows a vast improvement in symptoms associated with the chronic disease. And the literal review supports wider access to health education. All studies suggest that these positive impacts lower negative symptoms and lower adverse complications associated with this disease. And those who have more education are likely to have a better outcome. And I think that is it for us.
It's a great presentation. I really was drawn to, under your literature review, that second one that talked about health coaching, and that results that found that peer health coaching really improved diabetes control. You know, that seems like a role that is maybe underutilized, especially with the number of students that are looking to get that kind, you know, healthcare or health-related experience as they look at, you know, whatever that path might be next. That could be an excellent role for college students, like early career people in health, or people that, find themselves really drawn to that kind of role. That seems like a real niche in healthcare. And what a phenomenal role to be able to see direct results of your work in people adhering to whether it's medication or appointments. But man, that's a real interesting idea, and one that I hadn't heard too much about. I'm not sure if you guys, other people on the call, have heard a whole bunch about peer health coaching for one-on-one kind of clinical based coaching, but it's almost like a personal trainer for your medical care.
Yeah, and that was
Just to touch on that, the healthcare coaching, they just went through the program that the people went through was just 36 hours. So it really wasn't a time consuming program to become a health coach. And I mean, the increases in health outcomes were so drastic for so little time just given.
Yeah, and just to piggyback a little bit off of that, that's one of our, I think one of our bullet points is one of the biggest needs and change is the availability of educators and case managers that will aid in debunking this kind of misinformation that is believed in some communities as unhealthy, or there's different coping measures and self-treatment that may inhibit future treatment. So it's really important that that we highlighted this and that there is a lot more resources out there that a lot of people don't know about.
Absolutely. And I wonder for Lexi's group that just presented, if a program similar to that might also help related to pediatric diabetes. I know theirs was kind of more related to food deserts, but you just wonder if some of these roles might have a role in some other aspects too. So yeah, very, very, and you guys, did a great job.
Thank you.
Any other questions for their group? Yeah. Well, again, great job on this, and very presentation. I hope everyone on the call is kind of, again, paying attention to some of these topics, because there's some real interesting things that I think will serve you well as you go forward. We'll jump to our next group, which is team 12, correct? Or did we just do 12? Hang on, let me refer back to my.
We were group 11.
Okay. All right, so team 12, group 12, which is Alexandra, Maggie, Autumn, Alexis, and Anastasia. And their topic is impact of income on healthcare quality access in the United States. Interesting. I like how we've had some real diverse topics tonight. So we will turn it over to you.
Alrighty, so we had specifically telehealth in rural areas as far as healthcare access and quality goes. My name's Alexandra Guerra.
My name's Maggie Carey.
I'm Alexis Suave.
And I'm Autumn Espinoza.
So we focused on the PICO question of, does increasing use of telehealth improve access to health services in rural areas?
And we're going to start with what telehealth really is, and it's the use of digital information and communication technology, such as computers and mobile devices, to access healthcare services remotely and manage health. And I focused on the modes or the types of telehealth that we see. And if you live in a metropolitan area, kind of like Grand Rapids or around Michigan, a lot of areas, you are probably familiar with personal health records in the form of patient portals or health apps that you use with your providers. Another way is the use of Apple Watches or Fitbits for recording of vital signs, caloric intake, and physical activity. Our study found that synchronous, asynchronous, and remote monitoring were the three heavy types of telehealth across the nation. And I wanted to touch on the few other groups just talked about healthcare coaching, and that could be another use of like telehealth and how we use it with COVID. So those coaches could meet on Zoom. So now we can help people in rural areas who do run into those issues of not knowing what health is or having misinformation. And that's how we can use telehealth to help those individuals. And the significance of our project or our research was the use of technology can reduce referrals, streamline medical evaluations, and decrease the burden of some preventable diseases.
So next we looked at, we researched the current telehealth use and where within the United States telehealth is being used most. And so obviously with the current pandemic, the use of telehealth has increased by hospitals within the United States. And the graph on the left, underneath the current telehealth use, you can see that there. The figure on the right shows with shades of blue the number of hospitals that have adopted telehealth, and the darker the state, the higher number of hospitals where telehealth is being used in their system.
And then next, we talked about the impact telehealth has had on the quality of patient care. And so telehealth has had a huge impact on reducing the cost of quality healthcare, which has made it more accessible to people who may not have been able to afford it beforehand. And then according to a study done by J.D. Power, 6.2% of consumers believe that quality of healthcare in telehealth is higher than that of in-person doctor visits. And then 45.1% believe that it's the same. So overall, there's over 50% of people think that telehealth is the same or better than in-person doctor visits.
We also wanted to throw in some benefits of these hospitals that are utilizing the use of telehealth. It improves the coordination of care for patients. It helps with timely initial screening of symptomatic patients while minimizing the exposure in facilities and all while protecting both the providers and patients. And with the access of patient portals, patients and providers can manage their healthcare services at any time.
And I'm going to be touching on telehealth in rural areas more specifically. So a couple reasons why rural areas in general lack telehealth services. Mergers within larger healthcare systems, which are great for urban areas, they actually decrease access to regular in-person care, which is kind of a detriment to rural areas. And then technological barriers, specifically in rural areas, such as limited broadband connectivity and internet access, can definitely make telehealth a challenge to access. And then there's just the cost of equipment, training people on how to use the equipment, and then staffing, all in rural areas. So those are kind of some more logistical things. And also telehealth is not typically a part of traditional medical education given in medical schools. So there's also time needing to be invested in training physicians and how to conduct appropriate telehealth sessions. And then some benefits though, more specifically in regards to what telehealth can do for rural areas. It can increase access to care, specifically specialty care such as emergency services and cardiology, which prevents the patients the cost of having to travel, which can really be a benefit, especially if a patient is wheelchair bound. Telehealth also increases access to care providers in the nursing home settings, and they certainly have mobility issues. And it also can help avoid the cost and complications of hospitalization, which are higher in elderly patients. And lastly, telehealth can be used to educate physicians in rural areas so they can save the cost of traveling and the time of traveling. But that is all we have. Any questions?
Great job on this one. And as you know, this has exploded in the past year with obviously since COVID. We've had a couple speakers talk about this, and they touched on some of the same things you did related to, especially under why rural areas lack telehealth, that access to broadband or reliable broadband can be a big issue, especially in doing video type appointments with providers. But at the same time, it has especially we just did, I'm not sure if any of you attended our Lunch and Learn last week, they talked about the use of telehealth in mental health, community mental health, and it has actually increased adherence to appointments and everything due to the fact that people are able to do it from home. And so in some respects, there's, pros and cons, but I think that this is going to be here with us to stay. And, interestingly too, you talked about how there's not really a formal part of this in many curriculums like medical school. However, in the past year, because of the fact that they couldn't get into clinical settings, a lot of them were doing telehealth type work. So hopefully, if anything, this past year really forced the hand in allowing programs to see the importance of training students in this, because I think it has some huge benefits, especially like your topic talked about in rural areas. Any other questions for this group? Very, very timely presentation. Great job on this. This is really interesting and great to see some of this research, so thank you. I realized for our next group that I missed group 12, their team 12, when I was doing it. So that would be the group of Christina, Michael, Taylor, Grace, and Madison. And I think that was the poster that I accidentally read the last time. So team 12 had the impact of income on healthcare quality and access in the United States. So now that we have that correct, I will turn it over to team 12 for their presentation. I know we've got Chris call. There we go. Taylor, good job. Okay.
There we go. Sorry, I can't find the unmute button. Hello, my name is Taylor. I'll be doing the presentation for my group today. We have Christina, Michael, like you said, Madison, and Grace also in my group. And we mainly focus on the impact of healthcare quality and access in the United States. So we did the association. Is there an association, association between income and healthcare quality and access in the United States as our question overall. So our intro, really, there is a significant difference in the quality and access of healthcare people are receiving when it relates to income. So if you have a higher income, if you live in a higher income area, you're receiving a higher quality of care, which relates to if you're in a poor health, it's really related to low income areas. We had the opportunity to actually look at some stats in Michigan and related to income and healthcare, and healthcare factors and outcomes were better in the Michigan countries with greater levels of wealth. And it showed that 1 in 5 Michigan children live under the poverty line, which is like 20% that are under the age of 18. And also that 43% of the population in Michigan cannot afford needs such as healthcare. And during this COVID, it also got worse as well. And you can see that in figure 4, how our state overall value compared to the national. And then we have figure 1, which demonstrates the quality of healthcare for each state in the United States. So highlighted in gray, if you can see it, I know it's kind of small, but is the best quality of healthcare, and then highlighted in blue is the lowest quality of healthcare. So you can see that 25 out of the 52 states are around a good healthcare quality, but that means only 48% of the state is. So over half, 52% is in a low quality of healthcare. And then you see figure 2, which is the differences in income levels in the United States, which demonstrates the average income levels in the United States. The poorest households bring in around $14,000 annually, and the richest bring in $234,000. So that's a $220,000 difference. So the richest make 17 times the average of the poorest household, which shows like how income relates to the overall health. Then we have figure 3, which demonstrates the percentage of quality in different insurance groups. The uninsured experience worse quality is represented, and the privately insured experience better quality of healthcare. So the overall, as we like review these figures and such, the overall outcomes for predicting healthcare quality by income levels is an efficient method. Low income countries have poor health outcomes. So like low income can result in high risk for chronic conditions because you have lower income, so you're not gonna maybe go for little health care issues compared to, which could result in worse conditions. And then income is a social determinant of health, which is shown in figure 1 that where you're born and live affect the range of your health outcomes. So overall, like summary of this is that income levels in the United States are a determinant of health in any given area. As the income levels increase, so money goes up, your access to higher healthcare improves overall. So those who live in higher income areas have a better overall mental health and physical health because they have the ability to access better health due to their ability to have a higher income and be able to pay for the things that they need and go get those things done compared to people who have low income. And we determined that healthcare with these income levels is a clear indication that the healthcare system needs improvement, because we shouldn't, just people with low income shouldn't be able to get the care that they need just because of people who make sometimes more of what they do. I believe that is it. I don't know if anybody has any questions. I might not have covered anything if my group wants to say anything, but that should be it.
It was really great job, and it ties kind of into the earlier presentation we had that focused on this similar topic from a Michigan perspective, but this kind of gives the national perspective, and it really ties in really well. Questions for Taylor or her group? Yeah, really interesting, especially for those of you that are kind of looking at more healthcare on a macro scale or public health. I think some of these topics are just very interesting, and a lot of data I think supports it, both locally within the state and across the country. So great job. Thank you, Taylor. Really great job. So our last group tonight, because the group 2, Taylor and their group, I think was no longer able to participate. So do we have Emma P. and your team available? Should be, yep. Yes. Great, and I think, Emma, correct, I'm not sure if I did get yours on the website yet. If not, I will have that up there by tomorrow. Did you see it up there?
Last time I checked, I did not see it.
Okay. What I'm going to do is I'm going to put it under Team 2, because Team 2 actually pulled out of the, so I'm going to put yours right on the website under Team 2, and I'll have it done by tomorrow morning. So, because I've got your, I know you emailed it to me, and I'll get it up there. So with that, I'll turn it over to you and your team.
Is everyone able to see the poster?
Yep.
Yes.
Okay. So my name is Kimberly, and our group did our poster on high quality education in the health of children and adolescents. It was Alexander, Dontel, and Emma. And pretty much what we found is, like, obviously an education is a pathway that leads to better health outcomes in children and adolescents, and even later into adulthood. And that socioeconomic status determines how one practices health and wellness. And also, high quality education promotes stability, which includes improving practices of health and wellness, like maintaining a healthy body weight and seeing your doctor regularly. And also, children that are raised in an environment where practices of health are instilled daily throughout education and parenting have a greater health outcome even later into life. And so our whole PICO question pretty much was, how do opportunities in high quality education affect children and adolescents as a whole?
All right, so for the significance, individuals with a higher level of education are more likely to live a healthier and longer life. From this information, we can draw out that improving school quality and access to higher education could potentially lead to better health outcomes and longer life into adulthood. Studies have also noted an association between increased school quality and a decreased mortality rate. This study measured school quality by examining the pupil to teacher ratio, the average teacher wages, and then the length of the school year. And then improvements in each of these areas have been associated with a decreased mortality rate. And lastly, upon reaching adulthood, retrospective studies have linked education quality as being the principal pathway leading to financial security, stable employment, and social status. And each of these factors have been examined to lead to improved health outcomes into adulthood. For the literature review, parental decisions can affect children's health and education. Parents may invest in high quality schools and education and even move their child from a state with low quality schools to a state that offers higher quality education. In this instance, the parental investment could be the primary influence on childhood health rather than the education quality. Parents often do not consider that their own education will determine their children's education as well. Access to education and health service resulted in improved health status. Education and healthcare is not easily accessible to all areas of the world, and areas with access to higher education and healthcare have been found to show results of improved health status. And then improved school quality results in improved current and future health status. Higher quality education has been shown to result in improved current health status and improved health status later in life. A decreased incidence of health risk behaviors such as smoking or drug use, and then a lower prevalence of obesity, and then a decreased risk of mortality.
All right, and so for some of the outcomes in several of the references that we have, they each did a study of adolescents and adults later in life and what quality of education they had and how high an education they went to. And so we found that the higher of an education that a child had, they actually felt their self-health was better. So they felt better within themselves, their mental health was better. And those who have a better education are also less likely to struggle with obesity. So they're able to maintain a healthier body weight, and they actually feel like they want to exercise more, eat healthier. And children and adolescents are less likely to struggle with smoking if they actually have a higher education and a better quality of education. And those who receive more education are actually more likely to engage in exercise and maintain a healthy body weight, like I said. So even those who are in college and after, or even if they have a different degree than just a GED, they're likely to be more healthy. And also those who have a more education are less likely to have problems with alcohol and drugs and addiction issues. And also those who have a higher education or more better quality of education are more likely to get screenings for cancer and other health issues. So they're better with preventative medicine. So they're going to their doctor regularly, they're getting their blood work done, they're getting heart screenings, all that sort of stuff. And then our solutions, we pretty much kind of saw that pupil to teacher ratio made a big impact in how good of a quality kids have in high school and middle school and such. The length of the school year, and also the teacher wages. So if teachers aren't feeling that they're being treated adequately or getting paid what they should for all the time that they're doing and even having to put their own money into their students, then their classroom was a lot better and the teacher's able to give more of their education side. But also for our ideas, we thought that we should encourage children and adolescents to really consider trade schools and go into other fields and maybe not just go directly to college because it's not for them. From my personal experience, my high school did not push trade schools at all, and a lot of kids felt like they didn't even have to do anything. So I think if we push that a lot more, then kids are able to get different degrees like plumbing. Jobs are necessary to the fact that you'll still have benefits and be able to take care of your family and take care of your health. And also, as we've seen other presentations and that we've learned in other allied health science classes, those who seem to not have as much education struggle financially with job security and struggle with insurances and making sure that they're able to maintain a healthy lifestyle lifestyle. So if we are able to have better access to healthcare, then especially for people in lower income areas, then we're able to prevent health issues and help with addiction problems.
All right, as a summary, access to high quality education can be determined by an individual's poverty status, their socioeconomic status, their geographic location, and then parental decisions that are made for the child. High quality education is related to the health of children and adolescents because education prepares the child for the future. Children and adolescents are less likely to engage in unhealthy behaviors in higher quality education settings. And finally, it's important to ensure that children have access to high quality education. And I think that was it.
Great presentation, and certainly imperative importance with how many schools have been shut down, across the country, and some back in person, and some have gone back and had to go back to hybrid or not at all. And I think this really highlights the importance of education, especially, and we had a presentation earlier, related to literacy and the importance of reading, but how much some of these early interventions can really impact things going forward. So I found this fascinating. Any questions for this group on this topic?
I just want to say, Brian, I appreciate them bringing up that, other routes of education that are post high school. So
Absolutely.
I appreciated that.
Well, and in particular right now, there are fields that are just booming that, like construction is, you can't find a contractor if you are trying to get work done on your home. And, there's other fields right now that I think are just, people don't always think about, but are just really, really, especially if you have skills that lend themselves well to those kinds of things. There's phenomenal opportunity and will continue to be in many of those trade fields. So I thought that was a great point that you brought up. So I think that was our last group. Was there any groups that we missed tonight, or anyone that we skipped? I don't think so. Well, really, really great job. This was the first year that we changed topics to kind of the social determinants of health. And I found that the presentations and posters and the topics just really fascinating and very timely. And so I really, really thank you for the work that you've done. And I think, kind of I'll leave you with this to end, that the importance of this is not just having done it, but the lessons that you learned from some of the topics that you researched and learned about. I think ultimately the hope is that these will really carry forward with you as you go forward. And that's part of what this rich kind of educational experience is. It's certainly been disrupted, in some unique ways. But I think ultimately as you go forward past your collegiate years, whether that's into graduate professional school or right into the workforce, that recognizing some of these more broader societal impacts, especially as it relates to healthcare, I think are going to be important for you to be both successful contributing members of a society, but also for your work, whatever that might be. So really, really great job. I thought you all did excellent work on your posters, and I'm really impressed. Carrie, I don't know if you had any other final words for the groups or the students before we close.
Just want to thank the groups in my section. So of course I'm a little biased that way. So, but I thought everybody did a great job. So I just wanted the students in my section to be sure to know that I've been here and I appreciate their presentations, and it's been good to see other teams as well.
Brian, this is Chad Sullivan, and I can't tell you how excited I am to see and hear the students, not only in our sections, but all of them just really set the bar quite high. So thank you.
I agree, you really did. And, and one advantage I'll tell you guys of this format versus the live format is that, in the live format, it kind of is hit and miss depending on how many people might actually see your work. And in other words, let's say we had 30 or 40 groups and we had the same thing going on, some groups, depending on the traffic or their poster, might have more people stop by. The nice thing about this is you had a pretty captive, each group had a pretty captive audience. And that's kind of the nice thing about this style. And so it makes me kind of think about going forward, even if we are able to be in person next year, the best method to do this. But really great job. And I appreciate all of your hard work in this. And it was really, really fascinating. So with that, I hope that you all have a great evening. If any of you are interested in joining tomorrow, or even having it kind of on in the background to see some of the topics, we'd welcome you to do that. And at the very least, I really encourage you to go on the website and check out some of the poster for tomorrow evening, because there's some really excellent work. So, and I'll keep that up again. So that's not going away after this week. That'll continue to stay up. So if that's something you want to put on a virtual portfolio or something going forward, you can always link back to that. That'll be on our IPE office website. So great job again, and hope you have a great evening, and certainly reach out if you have any other questions. But I really commend all your hard work on this, and appreciate getting to see some of you virtually. So have a great evening, and we'll see you next time.